So I hope it's full screen and visible,
Yes,
the
yes,
screen.
yes. Yes.
Okay. Okay. Thank you so much, the feed team. I think it's always a pleasure interacting with the students on this platform. And all the best to all the students for the coming fellowship exams. So I did interact with few fellows also during last exams, and I did get a feedback that some of these programs are also part of your OSCEs, your Vivas, and also sometimes in the theory exams. So I have tried to actually cover it comprehensively in terms of enumeration of the various programs, how it all has started. And for a short note or for the OSCE and all, you can just jot down the points from this talk. And if you want more details, you can just search it, and the programs will be actually easily accessible on the websites. So I'll just enumerate so that you don't miss any latest programs and the updates in the community health which has come up. So let's start. So this is covering both maternal and newborn health because we know that both are interrelated and it's a diet, the mother and the newborn. So some of the maternal programs do affect the newborn also. So I'll just be covering those also in brief. So first of all, my the introductory slide for this talk, which seems to be a little dry and off for neonatology, is that why actually neonatology is important or why is it unique? It starts from the intrauterine period, and it's dependent on the mother and the adults, and has a lot of ethics issues covered with it. The in management is integrative. We can actually cover the spectrum of newborn care from level 1 to level 3, and we'll see what are the levels of care. It affects the human life cycle in a longer term. I mean, the interventions which you do or which you do not do any harm in the newborn period. It will be affecting the newborn throughout his life cycle. A lot of technology can be used to improve the outcomes, futuristic, and it is multidisciplinary from obstetrics and gynae to genetics and to long-term follow-ups also. A lot of preventive strategies can be applied. If applied in the newborn period, can actually avoid disability. Social sciences in terms of socioeconomic status, the interpregnancy intervals and all, and cultural facts which are actually we see during the newborn period. Those are also very relevant, and it's very dynamic and very upcoming and very rewarding also. So we start with the history of neonatology right from 18th century. The father of neonatology, Dr. Corney Braun. The first premature infant center was established in 1923, and the intensive care was first established in 1960. And now it's actually in 80s and 90s that actually the term newborn was coined, and newborn mortality rates were separately calculated in 1980s. And so this was the sort of first survey conducted by the organization and the team. And these were the first few ideas how the newborn care has come up. I'm covering this because this forms a story of how the programs have started. Initially, the newborn never used to be separate. It used to be a part of either obstetrics or pediatrics. So with these in the 1980s, when in India it started, I mean, we began to realize that yes, a separate intervention, separate equipment for newborns needs to be there. And from here, the programs and the newborn health actually started gaining attention. So this was one of the surveys where the state of India's neonatal units was depicted, and very few units in the beginning had separate resuscitation bags and equipments for the newborns, as we can see. Only 14 to 15%, 20% had infusion pumps and vital sign monitoring. So, with this survey, actually, the task force on minimal perinatal care began in 1982 in collaboration with the Government of India. And gradually, we started investigating where are the newborns dying, when are they dying, and how are they dying. And based on these, the programs are devised. So one should know that birth is the greatest risk of death and disability, and the time of birth and day one of life, it actually accounts for more than what to say 50% of the deaths. And if we look at the early neonatal period in the first 6 to 7 days of life, it's actually 75% of the deaths. So what does it mean? It means that interventions which lead from the immediate peripartum period to antenatal period to the peripartum and to the first few days of life, first 4 to 5 days of life, that can actually prevent 75% of deaths. So this slide is important because the policies are directed at this level. and who are dying and what is causing the deaths. So 80% of these babies combined, whether it is sepsis, pneumonia, preterms, these are 80% of the babies are small babies globally. And the first topmost causes are preterm birth, intrapartum complications, which is birth asphyxia, and neonatal infections. So as we see, the programs and the continuum of care focuses on maternal antenatal care, going on to complications during birth and after birth. So that is why these one or two slides are important, and perhaps that will be useful for you in your short notes also. So where are they dying? Are they dying uniformly across India in all the states, or is there a difference or a variation? I think by now we all know that India in itself is a many countries in itself. So the it varies, the mortality varies, and a few states contribute to more than 60% of the newborn deaths. And these are actually known as the empowering or the states which need improvement, so to say, EAG states. And these four EAG states actually contribute to more than 50 to 60% of the deaths. Globally, also we see because India is the most populous country, so the number of newborn deaths are also high. And in terms of absolute numbers, the current NMR as per the SMR SMS data 2019 is 22. And yeah, we'll take the questions. Gradually, we'll take the questions. And same is true for the stillbirths. Now, why stillbirths are important? Because many of the fresh stillbirths are actually ones, if intervened during the immediate antepartum period, would actually be live newborns, isn't it? So, whenever we see any program, the newborn mortality rate and the stillbirth rate, they go together. So, with this background, where are they dying, and why are they dying, and when are they dying, the newborns? So the challenges are there. So as per the SRS data 2019, the NMR is 22 per thousand live births, which is actually 73% of the infant mortality rate, which is 30. And it's 62% of the under 5 mortality rate, which is 35 per thousand. And there is a large variation. Kerala being at 5, Delhi being at 9 of NMR, which is comparable to any developed country, and ranging from 30 in Uttar Pradesh to 33 in Madhya Pradesh, 30 again in Odisha. So there is interstate variations which are seen. So how to save lives? And this is just to show again from the previous graph that preconception nutrition, antenatal care, and care during birth are the most common, interventions where we can save maximum number of lives. So with this background, we now go to how the newborn health and the program started. So the Millennium Declaration in 2000 actually in September, it was led to actually Millennium Development Goals. Before the SDG or the Sustainable Development Goals came, there was what we call MDG, which is 2001, which was a comprehensive goal of ranging from poverty to gender equality. And goal number 4 was reducing child mortality, and fifth was improving maternal health. The component of newborn was included in the child mortality one. So this way we developed MDG deadline or the goals by 2015. So after this, what happened? A high level meeting was conducted, and what they did was, okay, MDG is there, but post MDG, post 2015, what should be done? So a working group was formed, which then subsequently actually upgraded or elaborated on the Millennium Development Goals to what we now call as Sustainable Development Goals. So please do go through this, that there are how many goals are there. There are 17 goals, and which of these actually caters to the newborn health and the maternal health. So this is the SDG goal number 3, which has two targets, 3.1 and 3.2. The 3.1 target, it actually caters to reduction of the global maternal mortality rate to less than 70 per 1 lakh live births. And target 3.2 is concerning the newborn and the child mortality. So by 2030 to end the preventable deaths of newborns and children under 5. So where this target come from? This target actually has come from the Every Newborn series, which was published in Lancet, which was a very statistically strong series, which actually gave us the idea where the newborns were dying and how, at what rate should the newborn mortality improve so as to reach the goal by 2030. So this Every Newborn Action Plan was based on evidence from this series, and it was co-led by UNICEF and WHO in 2014. So, what was the goal of every newborn action plan? Now, I'm coming from SDG to newborn action plan because the goals of SDG are actually to reduce neonatal and preventable deaths in the newborn. And this ENAP, the Every Newborn Action Plan, gives a specific goal of reduction of newborn deaths to under 10, and subsequently and simultaneously stillbirth rate to under 10 also, and the global under 5 mortality rate of 8. So this is the global target. Every Newborn Action Plan is the global target by 2035. And based on this, every country has to adapt because every country is different. This was the global target which was given. So how did India adapt to this ENAP? We adapted to India Newborn Action Plan, where we decided to track every planned pregnancy, every birth to be attended. And the actually the ethos remains that we need to end the preventable deaths. However, the target is to achieve a single digit NMR and stillbirth rate by 2030. So the difference between the global and the Indian newborn action plan is the goal has to be achieved in India by, earlier by 5 years, that is 2030. Oh, so this may be asked that what is the goal of India Newborn Action Plan and where are we? So this is the projected decline in NMR. To achieve a single digit NMR of 9.9 or below 10 by 2030, we need to be at 15.2 in 2025. So we need to actually reduce the NMR very rapidly. The current rate may not be sufficient. So currently we are not even at 18.6, we are at 22. So what we see is we need a much rapid decline to achieve the NMR of single digit by 2030. And same is for stillbirths. So for stillbirths also, the reduction has to be very steep in order to reach the goal. So that is why these interventions are important. So whenever you get a short note or even if the goal of any program is asked, you should build a background of how the newborns are dying, why are they dying, and how to actually reach this goal. So INAP actually integrates a lot of pillars, which we call, and these pillars are based on the main core principles of this, that we have to converge, we have to do partnership with different organizations, equity of care has to be there, gender equality has to be there, especially for female feticide, infanticide, accountability and quality of care. So remember these 6 pillars for INAP, which were based on the previous 6 principles of care. So what are the 6 pillars of care? It starts from, it's easy to remember. It starts from the preconception period and the antenatal care, care during the labor and the childbirth, immediate newborn care of a healthy newborn, care of the small sick newborn, and care beyond survival, which is covered by the programs like Rashtriya Bal Suraksha Karyagram, which actually follows up the babies with limitations to actually limit the disabilities and prevent the disabilities. So all these interventions have to be started from the community and the family and have to be available at the outreach level or the sub-center level. And it has to be a continuous process till the tertiary level care or the medical colleges. So after the launch of India Action Plan in 2014, so a lot of reviews are done, a lot of quality assurance schemes are taken, tracking is done. So this is the timeline of India Newborn Action Plan, which you can just revise just before your perhaps a theory that what are the landmarks which were achieved in the INAP or the India Newborn Action Plan. So these are the principles that the plan was developed. We developed some dashboard indicators. There were quality assurance mechanisms. I will show you what are the mechanisms. There were institutional mechanisms and linkages of the care from sub-district and the district level to the medical colleges. And gender discrimination was also looked at. So simultaneously, what was happening? This occurred in 2014. The INAP which happened, no, that was in 2014. So the government also plans a plan for 5 years, each 5 years. So at the same time, 12 5-year plan was ongoing from 2012 to 2017, and it also laid down some of the targets. So if a query comes about the 5-year plan, so the targets for India, the government of India was to reduce IMR to 25, as against the INAP which has come up in 2014, where we had a target of single digit. So still you see 2012 targets a little liberal compared to the INAP targets, and same for maternal mortality rate, national fertility rate, and gender ratio. So this plan was till 2017, and now the 5-year plans have now been stopped. And what we are doing now is a think tank of the government, which is Niti Aayog, which lays out the programs. So Niti Aayog is the governmental organization or the think tank of the team, which focuses on more flexible programs. It's not a strictly target-based approach, but it's more about how integration of various programs can lead to improvement in the care. So the traditional 5-year plans were now dropped, and a more dynamic program was, or more dynamic organization was launched, which develops a shorter term action plans, not 5-year plans, but shorter term goals, 6 months, 1 year, 1.5 years, and then re-audits them to actually look at the change in the outcomes. So, what are the core principles of this Niti Aayog or the Prime Minister Action Plan? One should know about the National Health Policy also, and also about the PMJ and the Ayushman Bharat, which is there. So, you should know that Ayushman Bharat has two components, which is first component of Ayushman Bharat or the health and wellness centers is the ABHWC, which is strengthening of the primary health care or the wellness centers, and the secondary objective is to support the below poverty line people and population and give them financial protection, kind of insurance. So that is called Pradhan Mantri Jan Arogya Yojana. So these two components of Ayushman Bharat one should remember, because that is ongoing and it is the largest financial protection policy which is given by the government. So these should be remembered. So till now the story has been that we started with the Millennium Development Goals in 2000, 2001. It actually went on till 2015. And once 2015 came, then post 2015, globally, simultaneously, the Sustainable Development Goals were developed. So part of Sustainable Development Goal was Goal 3 and Goal 4, which actually catered to child development, child mortality, neonatal mortality. So a component and the parallel part of it is every newborn action plan, India newborn action plan. So we discussed these 3 or 4 issues, and these are actually implemented through 12th 5-year plan, which has now translated to Niti Aayog, and Niti Aayog is doing it through two main components, which is strengthening of the primary health care and giving financial protection. So this pyramid actually covers the same components, that the largest part still remains the peripheral or the comprehensive primary healthcare system, which now moves tertiary or the medical colleges and the level 3 NICU. So the pyramid remains that still primary and secondary form a major chunk of the care. So keeping this broader programs and where and how newborns are dying, now let us actually move on to the programs. So the programs actually go out into a continuum of care, starting from the reproduction, maternal, newborn child, and leading to adolescent health, plus newborn transport and links between the community and the healthcare facility. So this continuum of care has to be remembered, and whenever you write or speak, you should actually speak in language of linkages from the community to the healthcare and vice versa, from the healthcare to the community. So the transport is important, plus starting the reproduction and the maternal health and the adolescent girl health, that is also important. So this is the timeline of the continuum of care which started in 1981 with the which we saw that perinatal care package. It led to 1992, it led to Child Survival and Safe Motherhood Program, which subsequently evolved into what we now called as JSSK, or Janani Shishu Suraksha Karikram, which actually gives you free healthcare facility for pregnant women and newborn. Okay, so what we did was, through this, we all now have heard about facility based newborn care or FBNCs, through which is 548 is the older part. Now we have more than 1,000 sick newborn care centers or special newborn care centers where the babies are cared up till CPAP care. Okay, those are called level 2 care. And it also subsequently led to largest community-based program where you should remember home visits and ASHA workers. These two can be your short notes or an OSCE or a Viva, table Viva sort of thing. that what does a community level worker do, and what is the name of that community level worker, and what are the responsibilities of ASHA. So that may be asked. Okay. So starting from the maternal programs to enumerate are Janani Suraksha Yojana, Pradhan Mantri Surakshit Matritva Abhiyan, which is PMSMA, which was launched in 2016. Surakshit Matritva Ashwasan, which is Suman program 2019, which includes the transportation of the antenatal mother. Lakshya, which is the quality improvement of the delivery birthing areas, right from OTs and then birthing areas in the labor rooms also. Dakshata, which is the development of skill and simulation labs. Kilkari, which uses the mobile apps or the digital media to actually strengthen the antenatal counseling. So it also includes a lot of other programs which we may actually just go through or just remember it just before the exam. But the main thing to remember here is the last 4 months, which is the use of maternal and child protection card (MCPC), which you all should know. Anemia Mukt Bharat also should be known, that how maternal anemia is being treated. Information centers and behavior change communication, and stillbirth surveillance, which is an important part. As I said, fresh stillbirths actually form a part of sort of newborn. Fresh stillbirths are the ones, if saved, can actually lead to increased newborn survival. So, what is Janani Suraksha Yojana? It is a safe motherhood intervention which was started under National Rural Health Mission, which is again a part of the Reproductive Child Health Program (RCH), the continuum of care which we saw. And it is a modification of the maternal benefit scheme. What do we do here? We actually link the cash assistance to the mothers, which is linked to the antenatal care during pregnancy. And if the mother delivers at the institute and receives immediate postpartum care for 48 hours, then she is entitled for cash benefits. And this was actually introduced in the low performing states where the institutional deliveries were very less, that is less than 25%. And maternal package was 1400. Asha used to get a certain amount of money in the rural and the urban areas, and for high performing areas the enumeration was little lesser. So this is about the Janani Suraksha Yojana, which was actually now combined to the newborn health also, which is JSSK, which is Janani Shishu Suraksha Karikram. So newborn health was also linked along with JSY. So first was JSY. Now this is Pradhan Mantri Surakshit Matritva Abhiyan. We should remember that every ninth of the month, the mothers are actually given free antenatal care. And this guarantees a minimum package of antenatal care for women in the second and the third trimesters of pregnancy. You see now why is it important? Because we saw that birth asphyxia was the second most common cause of death where the babies were dying. And birth was the time when most of the babies were dying in the first day of life because of asphyxia. So these programs are all linked to the data which was shown earlier, where the newborns are dying and why they are dying. So these programs are linked to the antenatal and the immediate antepartum care. So that is why the strengthening of antepartum or the antenatal checkups. So second and third trimesters were targeted here with a minimum package, and you see they are giving cash incentives also, that the mother should come timely for institutional deliveries. The follow-up of high-risk pregnancy was also actually improved and identified. A sticker was there which was placed on the maternal and child protection card on each visit. So green sticker was for the woman with no risk factor, and the red sticker was for the woman with high-risk pregnancy. So these are all targeted at reducing the perinatal asphyxias and high-risk pregnancies to be referred early. This is Suman, where you see that it moved up from the previous two programs, that we now looked at the quality. Okay, we improved the institutional deliveries. We have now reached institutional deliveries up to 80% in the new latest SRS data. So how to improve the quality? So you see these are the mechanisms by which women's respect is there, respectful care during pregnancy. That is important, and that was the focus of Suman. That zero tolerance for any negligence, and we it should be made sure that all the programs which are running, those are actually implemented on the pregnant lady who is coming. Respectful care, 100% reporting of the deaths, grievance has to be addressed, feedback has to be taken, and champions have to be awarded. So this is the one step ahead of the previous programs in terms of appreciating the quality and the quality of the care and the respect the mother is getting during that care and adherence to the existing programs. Then the Dakshata. I think many of you who are working in medical colleges must have seen the skill labs. A lot of skill labs have been established under this program, and it empowers the providers to actually train the new recruits and also to train the nearby satellite areas and the periphery areas and the staff from those areas in simulation and skills. So it ensures that essential supplies are there in the labor room, and training is there on site. So these are some of the objectives that ANC toolkit is there, and the training material is there, improving the learning and adherence to the evidence-based protocols. So this is Dakshata. Lakshya program, which was launched in 2017, it was to improve the quality of care around birth, and it covers not only vaginal deliveries, it also covers cesarean sections. And the goal is actually to certify all the labor rooms and the birthing areas through a checklist or a dashboard indicators. We also have an app to assess the centers for Lakshya, and the aim is to achieve 75% of the targets. There are a lot of dashboard indicators there, around 50, of which we need that at least 75% of those should be covered by the facilities, and 80% of the beneficiaries should be benefited. The dashboard indicators for Lakshya include birth asphyxia, antenatal steroid cover, respectful care, availability of birth companion. So that was introduced in this program. The last one, the major one, is the Kilkari, in which we have now used the social media and the mobile and the technology. It was first launched in 2013 in Bihar. And in vernacular language, I mean in the local language, it delivers free time appropriate messages, a reminder to the family and the mother. So what happens when they receive a message on the mobile or the voice message, that the whole family is oriented. Yes, the mother has to be taken for checkups and whatever the reminders are there, and informative messages are given, iron and folic acid intake, regular checkups. So all these things are given free of cost, and the call costs are covered by the government. So now coming to the core newborn programs. So these all programs were directed at prevention of asphyxias, detection of high-risk pregnancies, which actually affect the health of the newborn. So these are some of the newborn programs, and I have tried to actually cover from birth till early intervention. So what are the programs? Promotion of institutional deliveries through JSY and JSSK. JSY is Janani Swasthya Suraksha, Janani Shishu Suraksha Karikram, JSSK. Home-based newborn care, HBNC. Navjat Shishu Suraksha Karikram, which covers the most peripheral areas, and IMNCI and FBNC, which cover the institutional trainings of the staff who are posted in the tertiary center and the district level hospitals. We also have program for skilled care at birth, and leading to what does skilled care at birth and this institutional care lead to? It leads to early identification and follow-up, a good follow-up of the high-risk babies, and this is done through RBSK program or the Rashtriya Bal Suraksha Karikram, and subsequently a good detailed death reviews, not only of newborn deaths but also of the child deaths, to improve the care and correct the system errors which are occurring. So that it helps, actually the audit helps in that. So I said JSY was there, which was only for mothers. So it has now evolved into JSSK, which is Janani Shishu Suraksha Karikram. It was launched in 2011, where not only all pregnant women get free of cost delivery and consumables, but also all sick neonates up to 30 days, which was kept initially. And now in 2013, it has been extended to infants up to 1 year of age. So this is a common OSCE question which may come, that what is the beneficiary of JSSK? It is infants up to 1 year of age and all the pregnant women who are delivering at institutes. So NSSK, what is NSSK? Navjat Shishu Suraksha Karikram, which it was launched in 2009, and it actually covers the most basic newborn center, which is NBSU, Newborn Stabilizing Unit, where we have given an algorithm to basic algorithm of basic resuscitation, and we give the training for basic care of the essential newborn care, which is breastfeeding, identification of danger sign, identification of jaundice. So the training package covers the most peripheral or the most basic newborn healthcare centers, and we try to train the sisters and the doctors who are involved in the delivery and the newborn care. So this is the flip chart based approach. And the higher facilities actually are covered through IMNCI, or the Integrated Management of Child Illness, which has evolved into newborn also, FIMNCI. So IMCI becomes IMNCI, which is FIMNCI, facility based newborn care. And it has now also been converted to digital learning package or online package. One thing you all must know is facility-based newborn care, which is actually a higher, the upgraded version of NSSK. NSSK was based on the delivery room care, jaundice, breastfeeding. So facility-based newborn care not only covers the newborn care corners, but also covers the special newborn care units. So here you should remember that there are three kinds of care which are mentioned in under the facility-based newborn care. The most basic or the primary health care is the newborn care corner. A newborn care corner should be present in all the delivery or the birthing areas, whether it is a primary health care center or a community health center. Here, the basic care is provided for term, low-risk babies who are delivered in the facility, and we have to provide essential newborn care to the babies and timely referral if any danger sign is identified. The second level of care is newborn stabilizing units, which should be there in the community health centers, where a little higher therapy can be provided, like phototherapy, assisted feeding. And in case the babies need referral, they should be referred to the nearest special newborn care center, which are the level 2 or center, the first referral units, the level 2 centers, where now we have upgraded the SNCUs to care being provided to babies who are between 1000 to 1800 grams, and who can actually be provided with CPAP also. So these three levels of care are there in FBNC, okay, facility based newborn care. So once we have provided the facility-based newborn care, I said that timely referral for early intervention should be done for high-risk babies to prevent the disabilities. So one should know about the Rashtriya Bal Swasthya Karyakram, which has 4 Ds. So all should know the 4 Ds. Can somebody type in the chat box if somebody is not getting bored? What are the 4 Ds which are covered in RBSK? Anybody? Defects, diseases, delays. Last one, development. Okay, just go through the RBSK program. Yes, I think you are typing. So here under the RBSK, you have DEIC, what is known as DEIC, District Early Intervention Centers. And if somebody, some of you have visited any of the centers, you must have seen there is a multidisciplinary team which is there, and government has been really active in actually enrolling psychologists, developmental specialists. So all these ophthalmologists, so all these people are there who can do actually early intervention and prevent the disability. Okay, so this is RBSK, which you should be knowing. So coming to the ancillary, I won't say ancillary, but the important adjuvants to the care at birth. So this is mostly related to care at birth, care in the facility, and referral. So this is medical management, and the supporting programs are there, like how to improve the feeding. Okay, the baby is there in the facility. We are treating the sick babies. We are referring them to the higher center or to the DEICs. But then simultaneously, what is important? Timely immunization and good nutrition. So there are an umbrella of programs which cover the newborn from all the sides. So feeding is important. So Ma, IYCF, deworming, anemia, Mukh Bharat, Poshan Abhiyan, establishments of lactational centers, which is Comprehensive Lactation Management Center or CLMC, and associated lactation management units to promote breastfeeding, and then subsequently eradication and elimination of certain diseases like tetanus. So maternal newborn tetanus elimination, vitamin A supplementation, universal immunization program. So these are the umbrella of the newborn. So the newborn is there with us in the NICU, but there are certain programs to protect the baby and to actually improve the nutrition and the timely immunization. Indradhanush and intensified Indradhanush. So why do we need MA or the intensified program? Because still the breastfeeding rates are 40 to 50% as per the latest data also. So this was an intensified program which was an attempt to bring undiluted attention to this part. Okay, it was launched in 2016. So what are the components? And this is the commonest one which is asked in the table viva, because this is most directly related to newborn and newborn feeding. So breastfeeding awareness, one should always be aware of the benefits of breastfeeding and how to enhance breastfeeding. So it has four components: awareness generation through enabling environment, mass media, social media, community level interventions, health facility strengthening through use of nurses and ANMs, and monitorings, recognitions. Hospitals are accredited and awarded, those who are actually adhering to the programs. A step ahead of Ma is beyond 6 months, which is infant and young child feeding, which is again a very, very comprehensive model. It not only focuses on the breastfeeding and troubleshooting of the breastfeeding, it also focuses on what kind of complementary feeding should be started, when it should be started, what should be the content, what should be the quality of the complementary feeding. So it's a very good module, a comprehensive module, which is IYCF for the infant and young child feeding. You should just go through it, and it gives the feeding practices for children up to 2 years of age. Immunization is another area which we should not be missed. We should not be missing as a neonatologist, and this is the strengthening of routine immunization through Indradhanush initiative. Polio is one of the diseases which actually has now reaching the end of the elimination, measles elimination, and tetanus elimination. Also, one should know about the newer vaccines, when it should be provided, rotavirus, the MR instead of MMR, role of injectable polio vaccine. So, what should be the goal of the immunization coverage? So you should also know that now we are switching the polio switch from oral to IPV. And the end game strategic plan was actually planned from 2013 to 18, where the plan was to withdraw the oral polio vaccine and introduce the inactivated vaccine. So from trivalent, we switched over to the bivalent oral polio vaccine over 156 countries. And gradually we need to actually, the plan is to withdraw the oral vaccine. So this is ongoing strengthening of routine immunization services. Polio eradication, one should know about when the polio was eradicated. There can be just a short note or just a question on the Viva that why we still need to give oral polio, because our neighboring countries are still having polio. So we want to actually reduce the transmission. Till all the countries are eradicated of polio, we cannot actually remove oral polio vaccine. So while polio is still reported from Pakistan and Afghanistan. So tetanus was eliminated in 2016, and it was India was declared tetanus and yaws free. Indradhanush, one must note, and the coverage goal should be 65% initially in 2014. Now we say that coverage should be at least 90% for immunization. And in this, seven diseases were covered, and it has been now intensified to cover four more vaccines, which is Japanese encephalitis, rotavirus, pneumococcal, and MR vaccine, in addition to the seven vaccines which were there. And previously, the Intradhanush covered till 2 years of age. Now it's up till 5 years of age. Okay. And it also uses the UWIN digital platform. Like COVID used CoWIN platform, it is using UWIN platform, digital platform. As I said, there are deaths which will happen and morbidities and mortalities which happen. So it's important to have a child death review to identify the geographical variation, to initiate specific interventions, both at the community and the facility level. So there is a audit of stillbirths and neonatal deaths by WHO. Audit guide is there, and I think most of the ministerial programs. We also attend many child death reviews for our state in Delhi. I'm sure in your states also it must be happening. So to summarize, I think these are the high impact interventions, simple interventions, but they are high impact. Though ventilation and all, it actually may be less than 10%, but then these are the areas where if we intervene as a community or as a health policy, we'll be getting the maximum benefits. And most of the programs are targeting this, the labor and the delivery area, high risk pregnancies, resuscitation, essential newborn care, stress on breastfeeding, home visits, community care, and KMC, care at delivery point, and postnatal care with strengthening of facility care. So also know about a few words about who are doing this, who is doing this work. So these are the Anganwadi workers and the ASHA in the community. And how are we improving the quality? There are certain programs for quality assurance also. I'll discuss that in briefly. So Asha, one should know the full form is Accredited Social Health Activist. She's an honorary worker, part of the community only. She's from the community, chosen from the community, voluntary, and there are performance-linked benefits to her, incentives, financial incentives to her, and it varies program to program. She has been given a lot of work from home-based newborn visits till tuberculosis identification also. So you see there per population, there should be for 1,000 population. I think there is one Asha who is there, and there are some financial assistance which are given. And she has to work, of course, in coordination with the Anganwadi worker, who is her companion, and then medical officers of the community. So what are the implementation programs and the quality improvements? This is Muskan. Muskan is again ensuring child-friendly services in the public health facilities. It has a lot of checklists to assure that infrastructure is there, protocols and processes are there, grievance addressal is there, and patients and children feedback is taken, and the MBS is also looked at. So respectful, dignified care, protocols and management, infrastructure, which should be friendly, and follow-up and referral facilities. So these are the four pillars of Muskan. Indian public health standards. Now you may say that we are okay talking big things that they should happen, but then what are the standards which should be followed? So we have a set of uniform standards which are provided by Indian public health standards. And they give us the standards of how the infrastructure should be there in the sub center, in a CHC, in a district hospital, in a tertiary care hospital. What should be the manpower? What should be the services which should be there? So we have IPHS for that. I think this I have covered. Just to give you the picture, this is the newborn corner, which should be present in all the birthing areas. A warming device, a resuscitation kit. This is the stabilization unit where a warming device is there, plus basic care of warming and phototherapy is there. And this is a special newborn care center where a little higher than the NBSU facilities are there. So these are the three facilities which I talked about in the facility-based newborn care. Don't forget that without the integrated programs, the NICUs and the peripheral newborn health may not improve, which is use of appropriate antibiotics, continuous water supply, power supply. How would we work without that, isn't it? Without water supply, we cannot assume that hand hygiene will happen. Without sanitation, we cannot expect that newborn sepsis will be controlled. So these are some of the programs which integrate with the core neonatology programs. And regarding ROP, this actually aligns with the National Program for Prevention of Blindness and Visual Improvement. And for hearing screening, it aligns with the National Program for Prevention and Control of Deaths deafness. So there are certain data which need to be looked at. How do we know that we are improving? So these are the vital statistics and the demographics which give us periodic updates, and every 5 years these data are collected. One is sample registration survey, which actually is a home-to-home survey. National Family Health Survey, which is a more comprehensive survey, which includes the social background of the entire country. And based on these, the ministry prepares the annual health report, which gives all the vital statistics. And globally, it is integrated with the other countries or compared with the other countries by UNICEF and the WHO data. So these are the national data, and I can share, I think I have shared in previously also. The latest one is National Family Health Survey 5, which is 2019-20, and SRS 2019. So these give you the key indicators from neonatal mortality to birth rate, infant mortality, like I have shown here. So you can just go through the document. For whole India, it gives, urban, rural also it gives, and it compares with the previous, which is 2015. This is NFHS 5. The neonatal mortality, we have actually improved, but the improvement has to be faster. So it was 29.5 in 2015. And you see, urban has actually reached 18, the NMR, but the overall still remains 24.9. And as per the SRS, the latest, it is 22 actually, the neonatal mortality rate for entire country. For urban areas, it's 13, and you see there is a discrepancy in rural and urban. There is variation. So it also gives you the trends and the state-wise data. So for your own states, you should know whichever state you are working in. and also a word about the new MTP Act and the IMS Act, which is important for us. So the new MTP Act actually extends the gestation of MTP to 24 weeks, and also it gives unmarried women also the right to actually abort. And beyond 24 weeks also, if there is substantial fetal abnormalities, it has extended the limit. And if the medical board is there, one can also think of aborting a grossly malformed baby, and the fine is also different. So this is again one other act which we all should know, that we should not be promoting or advertising any milk substitutes which is there. And BPNI is one organization which actually advocates strongly against feeding bottles and infant feeds. Okay. So these are some of the alliances and collaborations. Just remember the names: KMC Foundation India, World Breastfeeding Alliance, Helping Babies Breathe, KidROP is for ROP, okay, Newborn Resuscitation Program, which is happening all across India. There are ICMR, SDG, or the Standard Treatment Protocols, and then BPNI and BFHI. Anybody can type what is BPNI and BFHI? Just to wake you up. So those who are from Karnataka, they must be knowing that KidROP is one program in which they are using the red cam, and they are actually screening the babies from distance, the ROP baby. I mean the babies who need to be screened for retinopathy or prematurity. They are using the technology, and we also have a health monitoring system. All the data is linked online through health tracking system, and we need to enter our data into softwares, and it captures multiple data. Also remember days, just for, I mean, your own interest also, and for exam point of view also. When is the World Breastfeeding Week celebrated? When is the World Prematurity Day? Anybody? World Prematurity Day, anybody? Very good. So BPNI, many people know. BFHI is Breastfeeding Hospital Initiative. Very good, Rajiv. So yes. Breastfeeding week is 1st to 7th August. Prematurity day is 17th November. Newborn week is again towards that week only, 15th to 21st November, in the November only. World Immunization Week, World Hand Hygiene Day, National Nutrition Day, Universal Health Coverage Day. So these days should be known to you just as a part of being a neonatologist. Uh, to end this, I think our targets will now, I mean, be more challenging because of the Viksit Bharat 2047 targets. So we may get a new target of NMR of 3.5 in the coming years. That marks the 100 years of our independence. So we may soon, by next year, we may get new targets for Viksit Bharat or developed country. The idea is to develop, I mean, make India a developed country in true sense. So the four pillars are there, and women are one of the pillars. So I'm sure maternal and child health will actually see updated targets by next year. So with that, I think I would like to thank you. Any more documents or details, I would be happy to share. It was already becoming a long talk, so I had to just touch upon it. Ready to take questions if any. Mostly, I think it's a factual thing, and you should be aware of the status of newborns in. Yes, yes, I'll share. So you should be able to know the data. I'll share the documents also, NFHS 5 and SRS also. So just to have an idea, where are we as a country? Yeah. Dr. Kavita? Rajesh, sir? Thanks.
Thank you, Dr. Pratima. I think comprehensive coverage, both I think exam point of view also, and just like a neonatal physician, everybody should know, because when you're treating patients, you should know what they are entitled to. So all these programs, so that you don't limit yourself in treating and giving optimal care to all mothers and babies who come to you. So excellent session, Dr. Pratima. We'll give them 2 minutes to see if they have any questions, or we can then
Sure,
wrap up.
sure, sure.
Thank you so much.
Thank you, thank you. Yes, Ramya. For newborn screening in Delhi, we have a program, NEEV program, which is ongoing. So under that NEEV program, we are screening the newborns through pulse oximeter. For hearing assessment, we are screening through OAE, and we are also screening for 17 OHP for disorders of sexual disorders and thyroid also. Yeah, we have NEEV. I'll put it in the group for you people. And what is the other question? What is facility-based breastfeeding program? It's not facility-based breastfeeding program. So for breastfeeding, you have MA, you have BFHI and BPNI organization, which actually accredits the hospital as BFHI friendly hospital, baby friendly hospitals. So where they actually see that what's the true indication of giving a top feed or a complementary feed? How many babies are exclusively breastfed? So these three programs combined are actually implemented in the facilities. So these three form the core of the breastfeeding strategies. Any specific program for neurodevelopment outcome of sick newborns? So program is RBSK, and that's the largest program I know of that links the development of the baby to the intervention, to DEIC. So in that RBSK only, there is evolution of higher interventions like precise management of cerebral palsy, opthal abnormalities, visual abnormalities, hearing abnormalities, psychological evaluation, autism. So these have been added so into that only, into RBSK. So I'll try to search, but I don't remember of any other sick newborn neurodevelopment outcome. So I'll share NAVE, I'll share SRS, I'll share NFHS, and I'll share the PowerPoint with Dr. Kavita. If you all are there in the group, I can share in the group also. Okay. So I'll mail the PowerPoint to you, Dr. Kavita. I think you can share if they have a broader group or some other group.
Yeah, if they
So,
have. If you can share it with me, then I can send it to Sarita. Sarita will share it with the others.
okay,
You
fine.
can share. If you're okay to share the PowerPoint, then yeah.